Late Intrauterine Fetal Death and Stillbirth. Green Top Guideline number 55, October 2010. Background. Stillbirth is defined as a baby delivered with no signs of life known to have died after 24 completed weeks of pregnancy. Intrauterine fetal death refers to babies with no signs of life in utero. Stillbirth is common, with 1 in 200 babies born dead. This compares with 1 sudden infant death per 10,000 live births. Overall, over 1/3 of stillbirths are small for gestational age fetuses, with half classified as being unexplained. It has been speculated that rising obesity rates and average maternal age might be behind the lack of improvement. A systematic review identified this as the more prevalent risk factors for stillbirth. Diagnosis. What is the optimal method for diagnosing late IUFT or intrauterine fetal death? Auscultation and cardiotocography should not be used to investigate suspected IUFT. Real-time ultrasonography is essential for the accurate diagnosis of IUFT. Ideally, real-time ultrasonography should be available at all times. A second opinion should be obtained whenever practically possible. Mothers should be prepared for the possibility of passive fetal movement. If the mother reports passive fetal movement after the scan to diagnose IUFT, a repeat scan should be offered. Auscultation of the fetal heart by peniard stethoscope or Doppler ultrasound is insufficiently accurate for diagnosis. Auscultation can also give false reassurance. Maternal pelvic blood flow can result in an apparently normal fetal heart rate pattern with external Doppler. Real-time ultrasound allows direct visualization of the fetal heart. Imaging can be technically difficult, particularly in the presence of maternal obesity, abdominal scars, and oligohydramnios, but views can often be augmented with color Doppler of the fetal heart and umbilical cord. In addition to the absence of fetal cardiac activity, other secondary features might be seen: collapse of the fetal skull with overlapping bones, hydrops, or maceration resulting in unrecognizable fetal mass. Intrafetal gas within the heart, blood vessels, and joints is another feature associated with intrauterine fetal death that might limit the quality of real-time images. The ultrasound findings of severe maceration and gross skin edema can be discussed with the parents. Although evidence of occult placental abruption might also be identified, the sensitivity can be as low as 15%. Even large abruptions can be missed. What is the best practice for discussing the diagnosis and subsequent care? If the woman is unaccompanied, an immediate offer should be made to call her partner, relatives, or friends. Discussion should aim to support maternal and parental choice. Parents should be offered written information to supplement discussions. Late intrauterine fetal death or late IUFT poses particular difficulties as it is often sudden and unexpected. A crucial component is to determine the emotional feelings and needs of the mother and her companions. This empathetic approach seeks to identify and understand women's thoughts and wishes, but without trying to shape them. Pregnancy loss can quickly result in vulnerability. Imposing care can worsen the psychological impact. Carers should neither persuade parents nor make assumptions that would limit parental choice. Initial discussions can be used to emphasize choice in decision making. Investigation of the cause of late intrauterine fetal death. What are the general principles of investigation? Clinical assessment and laboratory tests should be recommended to assess maternal well-being, including coagulopathy, and to determine the cause of death, the chance of recurrence, and possible means of avoiding further pregnancy complications. Parents should be advised that no specific cause is found in almost half of stillbirths. Parents should be advised that when a cause is found, it can crucially influence care in a future pregnancy. Carers should be aware that an abnormal test result is not necessarily related to the IUFT. Correlation between blood tests and post-mortem examination should be sought. Further tests might be indicated following the result of the post-mortem examination. Systems that use customized weight charts and capture multiple contributing factors should be used to categorize late intrauterine fetal deaths. Tests aim to identify the cause of late IUFT and so provide the answer to the parent's question why. 95% of women stated that it was important emotionally to have an explanation of their baby's death. Another important purpose of investigation is to assess maternal well-being and ensure prompt management of any potentially life-threatening maternal disease. This includes a detailed history of events during pregnancy and clinical examination for preeclampsia, chorioamnionitis, and placental abruption. There is also a moderate risk of maternal disseminated intravascular coagulation or DIC, 10% within 4 weeks after the date of the late intrauterine fetal death, rising to 30% thereafter. This can be tested for by clotting studies, blood platelet count, and fibrinogen measurement. Tests should be repeated twice weekly in women who choose expectant management. It is important to recognize that there is a distinction between the underlying cause of death, the disease process, the mode of death, for example, asphyxia, and the classification of the death, for example, growth restriction. Conventional diagnostic systems fail to identify a specific cause in about half of intrauterine fetal deaths. The proportion of unclassified late IUFTs can be significantly reduced with systems that use customized weight for gestational age charts, such as the relevant condition at that or the RCOG system, or systems that capture multiple and/or sequential contributing factors. An abnormal result may not be linked to the IUFT, but rather be simply an incidental finding. Comprehensive investigation can be important even though one cause is particularly suspected. With a very obvious cause such as massive abruption, non-lethal fetal malformations might be identified at postmortem that would only have been revealed had the baby lived. Are there any special recommendations for women with an IUFT who are rhesus D negative? Women who are rhesus D or RHD negative should be advised to have a Clay-Howard test undertaken urgently to detect large fetal-maternal hemorrhage or FMH that might have occurred a few days earlier. Anti-RHD gamma globulin should be administered as soon as possible after presentation. If there has been a large FMH or fetal-maternal hemorrhage, the dose of anti-RHD gamma globulin should be adjusted upwards, and the Clay-Howard test should be repeated at 48 hours to ensure the fetal red cells have cleared. If it is important to know the baby's blood group, if no blood sample can be obtained from the baby or cord, RHD typing should be undertaken using free fetal DNA or FFDNA from maternal blood taken shortly after birth. Major fetal-maternal hemorrhage or FMH is a silent cause of IUFT, and a Clay-Howard test is recommended for all women to diagnose the cause of death. In those women who are RHD negative, the potentially sensitizing bleed might have occurred days before the death is recognized, threatening the window for optimal timing of anti-RHD gamma globulin administration 72 hours. Anti-RHD gamma globulin provides reduced benefit when given beyond 72 hours up to 10 days after the sensitizing event. Persistent positivity of the Clay-Howard is often because the baby's group is also RHD negative, but might occur with very large RHD positive fetal-maternal hemorrhages. If it is important to distinguish between the two, the baby's blood group can be typed using conventional serology on cord blood. Typing with free fetal DNA or FFDNA from maternal blood is also available. What tests should be recommended to identify the cause of late intrauterine fetal death? Tests should be directed to identify scientifically proven causes of late intrauterine fetal death. Commonly associated antepartum conditions include congenital malformation, congenital fetal infection, antepartum hemorrhage, preeclampsia, and maternal disease such as diabetes mellitus. The common causes of interpartum death include placental abruption, maternal and fetal infection, cord prolapse, idiopathic hypoxia-acidosis, and uterine rupture. Transplacental infections associated with IUFT include cytomegalovirus, syphilis, and parvovirus B19, as well as listeria, rubella, toxoplasmosis, herpes simplex, Coxsackie virus, leptospira, Q fever, and Lyme disease. Malaria parasitemia has also been associated with stillbirth. Ascending infection with or without membrane rupture with Escherichia coli, Klebsiella, Group B Streptococcus, Enterococcus, Mycoplasma and or Urea plasma, Haemophilus influenza, and chlamydia are the more common infectious causes in developed countries. Table number 1. Tests recommended for women with a late intrauterine fetal death. What precautions should be taken when sexing the baby? Parents can be advised before birth about the potential difficulty in sexing the baby when appropriate. Two experienced healthcare practitioners, midwives, obstetricians, Neonatologists or pathologists should inspect the baby when examining the external genitalia of extremely preterm, severely macerated, or grossly hydropic infants. If there is any difficulty or doubt, rapid karyotyping should be offered using quantitative fluorescent polymerase chain reaction or QF-PCR or fluorescence in situ hybridization or FISH. Errors in fetal sexing can result in severe emotional harm for parents. Extreme prematurity, maceration, and high drops can all make the diagnosis difficult. If the sex cannot be determined clinically, or if there is any difficulty or doubt, the genetic sex can be tested rapidly on skin or placental tissue even of macerated babies. QF-PCR with additional Y chromosome markers can provide a highly accurate result within 2 working days in more than 99.9% of samples. Sexing can also be performed rapidly and reliably by FISH. If these techniques fail, sex can be determined on cell culture or at postmortem, but these methods can take longer. If the genital sex is not clear and the parents do not wish for postmortem testing in any form, they might wish to judge the sex themselves for registration purposes, perhaps based on an earlier scan, or ask the midwife or doctor to make a judgment. Other parents might choose not to sex the baby and give a neutral name. Stillborn babies can be registered as having indeterminate sex. What is best practice guidance for cytogenetic analysis of the baby? Written consent should be taken for any fetal samples used for karyotyping. Samples from multiple tissues should be used to increase the chance of culture. More than one cytogenetic techniques should be available to maximize the chance of informative results. Culture fluid should be stored in a refrigerator and thawed thoroughly before use. Karyotyping is important as about 6% of stillborn babies will have a chromosomal abnormality. Some abnormalities are potentially recurrent and can be tested for in future pregnancies. Culture potentially provides the greatest range of genetic information, such as trisomies, monosomies, translocations, major deletions, and marker chromosomes. Microdeletions have to be requested specifically, usually according to the result of any postmortem examination. If all cultures fail, QF-PCR can be performed on extracted DNA. Many laboratories are moving towards DNA-based methods for routine chromosome analysis, avoiding the need for cell culture. It is a reliable, less than 0.01% failure rate, efficient, and cheap technique for detecting common aneuploidies. It provides slightly less detailed, limited genetic information and is unreliable for the detection of translocations and marker chromosomes. Contamination with bacteria is an avoidable reason for failure to obtain results. culture fluid containing antibiotics can reduce this risk. Perinatal specimens suitable for karyotyping include skin, cartilage, and placenta. Skin specimens are associated with a higher rate of culture failure, approximately equal to 60%, twice that of other tissues, including placenta. Placenta usually has the advantages of being the most viable tissue and of more rapid cell culture, but the disadvantages of maternal contamination and placental pseudomosaicism. The next best is cartilage, for example the patella, but cartilage is harder to sample. Amniocentesis can also provide cytogenetic results if the mother chooses expectant management. Placental biopsy, approximately 1 cm diameter, should be taken from the fetal surface close to the cord insertion to avoid tissue of maternal origin. Skin biopsy should be deep to include underlying muscle about 1 cm in length from the upper fleshy part of the thigh. The skin can be closed with wound adhesive strips and tissue adhesives. What is the guidance on perinatal postmortem examination for maternity clinicians? Parents should be offered full postmortem examination to help explain the cause of an intrauterine fetal death. Parents should be advised that postmortem examination provides more information than other, less invasive tests, and this can sometimes be crucial to the management of future pregnancy. Attempts to persuade parents to choose postmortem must be avoided. Individual, cultural, and religious beliefs must be respected. Written consent must be obtained for any invasive procedure on the baby, including tissues taken for genetic analysis. Consent should be sought or directly supervised by an obstetrician or midwife trained in special consent issues and the nature of perinatal postmortem, including retention of any tissues for clinical investigation, research, and teaching. Parents should be offered a description of what happens during the procedure and the likely appearance of the baby afterwards. This should include information on how the baby is treated with dignity and any arrangements for transport. Discussions should be supplemented by the offer of a leaflet. Postmortem examination should include external examination with birth weight, histology of relevant tissues, and skeletal x-rays. Pathological examination of the cord, membranes, and placenta should be recommended whether or not postmortem examination of the baby is requested. The examination should be undertaken by a specialist perinatal pathologist. Parents who decline full postmortem might be offered a limited examination, sparing certain organs, but this is not straightforward and should be discussed with a perinatal pathologist before being offered. Less invasive methods such as needle biopsies can be offered, but these are much less informative and reliable than conventional postmortem. Ultrasound and magnetic resonance imaging, or MRI, should not yet be offered as a substitute for conventional postmortem. MRI can be a useful adjunct to conventional postmortem. It is essential to offer conventional postmortem examination to all parents, but in a way that allows free choice. All practitioners who discuss postmortems with parents have a responsibility to understand the process so that consent is fully informed. It was also recommended that the consent form should include sections on the purpose of the postmortem, the extent of the examination, possible organ or tissue retention and purpose, what should happen to tissues and organ after postmortem, and research and education. Postmortem examination of the baby and placenta has the highest diagnostic yield of all investigations. Postmortem examination might reveal the cause or causes and time of death, inform discussions of relevance to the risk of recurrence, and provide information for any medico-legal proceedings. There are published standards for the conduct of perinatal autopsies. Autopsies must include external examination and measurement of the baby. Independently of full autopsy, placental pathology is useful and should be offered even if a postmortem examination of the baby is declined. More restricted conventional postmortem examinations can be undertaken, but these are of very limited value unless there is a specific question about the organs the parents will allow to be examined. Limited postmortems are technically difficult and run the risk that the pathologist can inadvertently fail to comply with parents' wishes. Medical imaging can act as an adjunct to full postmortem, particularly of the brain and spinal cord. X-rays can show skeletal defects that are difficult to identify or categorize on dissection. Clinically useful information might be obtained from less invasive methods, including transcutaneous tissue biopsy, body cavity aspiration, and medical imaging, particularly whole body X-ray. Labor and birth. What are the recommendations for timing and mode of birth? Recommendations about labor and birth should take into account the mother's preferences as well as her medical condition and previous intrapartum history. Women should be strongly advised to take immediate steps towards delivery if there is sepsis, preeclampsia, placental abruption, or membrane rupture, but a more flexible approach can be discussed if these factors are not present. While women with intact membranes and no laboratory evidence of DIC should be advised that they are unlikely to come to physical harm if they delay labor for a short period, but they may develop severe medical complications and suffer greater anxiety with prolonged intervals. Women who delay labor for periods longer than 48 hours should be advised to have testing for disseminated intravascular coagulation or DIC twice weekly. If a woman returns home before labor, she should be given a 24-hour contact number for information and support. Women contemplating prolonged expectant management should be advised that the value of postmortem may be reduced. Women contemplating prolonged expectant management should be advised that the appearance of the baby may deteriorate. Vaginal birth is the recommended mode of delivery for most women, but cesarean birth will need to be considered with some. More than 85% of women with an IUFT labor spontaneously within 3 weeks of diagnosis. If the woman is physically well, her membranes are intact, and there is no evidence of preeclampsia, infection, or bleeding, the risk of expectant management for 8 hours is low. There is a 10% chance of maternal DIC within 4 weeks from the date of fetal death and an increasing chance thereafter. Vaginal birth can be achieved within 24 hours of induction of labor for IUFT in about 90% of women. Vaginal birth carries the potential advantages of immediate recovery and quicker return to home. Cesarean birth might occasionally be clinically indicated by virtue of maternal condition. The implications of cesarean delivery for future childbearing should be discussed. How should labor be induced for women with an unscarred uterus? A combination of mifepristone and a prostaglandin preparation should usually be recommended as the first-line intervention for induction of labor. Misoprostol can be used in preference to prostaglandin E2 because of equivalent safety and efficacy with lower cost, but at doses lower than those currently marketed in the UK. Women should be advised that vaginal misoprostol is as effective as oral therapy but associated with fewer adverse effects. A single 200 mg dose of mifepristone is appropriate for this indication. The use of misoprostol for induction of labor in women with intrauterine fetal death has been endorsed by the National Institute for Health and Care Excellence. The National Institute for Health and Care Excellence recommended that the choice and dose of vaginal prostaglandins should take into account the clinical circumstances, availability of preparations, and local protocols. A review of misoprostol use for late IUFT recommended that the dose should be adjusted according to gestational age, 100 micrograms 6 hourly before 26 plus 6 weeks, 25 to 50 micrograms 4 hourly at 27 plus 0 weeks or more, up to 24 hours. The systemic adverse effects such as diarrhea, vomiting, shivering, and pyrexia were more common with oral misoprostol. What is best practice for induction of labor for a woman with a history of lower segment cesarean section or Lscs? A discussion of the safety and benefits of induction of labor should be undertaken by a consultant obstetrician. Mifepristone can be used alone to increase the chance of labor significantly within 72 hours, avoiding the use of prostaglandin. Mechanical methods for induction of labor in women with an IUFT should be used only in the context of a clinical trial. Women with a single lower segment scar should be advised that, in general, induction of labor with prostaglandin is safe but not without risk. Misoprostol can be safely used for induction of labor in women with a single previous Lscs and an IUFT, but with lower doses than those marketed in the UK. Women with 2 previous Lscs should be advised that in general, the absolute risk of induction of labor with prostaglandin is only a little higher than for women with a single previous Lscs. Women with more than 2 Lscs deliveries or atypical scars should be advised that the safety of induction of labor is unknown. Mechanical methods of induction might increase the risk of ascending infection in the presence of IUFT. The Society of Obstetricians and Gynecologists of Canada recommended that misoprostol is contraindicated in women with previous cesarean delivery because of a high rate of uterine rupture. A more recent narrative review of induction of labor for late IUFT concluded that misoprostol can be used safely at lower doses for women with a previous cesarean, 25 to 50 micrograms. Misoprostol is off-label for this indication, however, and is not currently marketed in the UK at the doses recommended. These lower doses can be prepared in-house by dissolving a 200 microgram tablet in water. What are considered suitable facilities for labor? Women should be advised to labor in an environment that provides appropriate facilities for emergency care according to their individual circumstances. Maternity units should aim to develop a special labor ward room for well women with an otherwise uncomplicated IUFT that pays special heed to emotional and practical needs without compromising safety. This can include a double bed for a partner or other companion to share, away from the sounds of other women and babies. Care in labor should be given by an experienced midwife. What are the recommendations for intrapartum antimicrobial therapy? Women with sepsis should be treated with intravenous broad-spectrum antibiotic therapy, including antichlamydial agents. Routine antibiotic prophylaxis should not be used. Intrapartum antibiotic prophylaxis for women colonized with Group B Streptococcus is not indicated. Infection is a common association of late IUFT, and the mother can develop severe sepsis from a wide range of bacteria, including severe systemic chlamydial infection. Regardless of the primary cause of that, the fetus can act as a focus for severe secondary sepsis, including gas-forming Clostridial species, which can result in severe DIC. In one study, 3.1% of women with an IUFT develop signs of sepsis during induction of labor. It should be remembered that prostaglandins given to induce labor are associated with pyrexia. Are there any special recommendations for pain relief in labor? Diamorphine should be used in preference to pethidine. Regional anesthesia should be available for women with an intrauterine fetal death. Assessment for DIC or disseminated intravascular coagulation and sepsis should be undertaken before administering regional anesthesia. Women should be offered an opportunity to meet with an obstetric anesthetist. Analgesia is particularly important for women with an IUFT. All usual modalities should be available, including regional anesthesia and patient-controlled anesthesia. Diamorphine and morphine have greater analgesic qualities and longer duration of action than pethidine. They were rated more highly by laboring women in the National Birthday Study. DIC increases the chance of subdural and epidural hematomata with regional anesthesia. Maternal sepsis can result in epidural abscess formation. What are the recommendations for women laboring with a scarred uterus? Women undergoing VBAC should be closely monitored for features of scar rupture. Oxytocin augmentation can be used for VBAC, but the decision should be made by a consultant obstetrician. Fetal heart rate abnormality, usually the most common early sign of scar dehiscence, does not apply in this circumstance. Other clinical features include maternal tachycardia, atypical pain, vaginal bleeding, hematuria on the third specimen, and maternal collapse. No studies were found into the safety and effectiveness of oxytocin augmentation in VBAC with intrauterine fetal death. Women with previous cesarean section and a live fetus who need augmentation of labor have a 73.9% of achieving vaginal delivery. Puerperium. Where should women receive care before returning home? Women should be cared for in an environment that provides adequate safety according to individual clinical circumstance. Women with no critical care needs should ideally be able to choose between facilities which provide adequate privacy. Some women have acute medical problems after birth, for example, sepsis, preeclampsia, etc., with continuing critical care needs. Women without acute medical issues who do not want to return home immediately might wish to receive care within the hospital but away from the maternity unit if such a facility is available. What are the criteria for thromboprophylaxis? Women should be routinely assessed for thromboprophylaxis, but intrauterine fetal death is not a risk factor. Heparin thromboprophylaxis should be discussed with a hematologist if the woman has disseminated intravascular coagulation. Given the association of late IUFT with obesity, advanced maternal age, infection, and maternal disease, it is likely that many women with an IUFT fall into the moderate or high risk categories. What are the options for suppression of lactation? Women should be advised that almost one-third of those that choose non-pharmacological measures are troubled by excessive discomfort. Women should be advised that dopamine agonists successfully suppress lactation in a very high proportion of women and are well tolerated by a very large majority. Cabergoline is superior to bromocriptine. Dopamine agonists should not be given to women with hypertension or preeclampsia. Estrogens should not be used to suppress lactation. Suppression of lactation is of psychological importance for some women following IUFT. Up to one-third of women who use simple measures, such as a support brassiere, ice packs, and analgesics, experience severe breast pain. Bromocriptine inhibited lactation in more than 90% of women with few adverse effects. A single dose of cabergoline, 1 milligram, was simpler to use and had significantly lower rates of rebound breast activity and adverse events. Dopamine agonists are contraindicated in women with hypertension or preeclampsia. They can increase blood pressure and have been associated with intracerebral hemorrhage. Estrogen is of unproven benefit for lactation suppression and it increases thromboembolic risk. Who should be informed of events? All key staff responsible for care of the woman during pregnancy and afterwards should be informed of events. All existing appointments should be canceled. Maternity units should keep a list of likely departments that need to be contacted. All key staff groups must be informed to ensure cancellation of existing appointments and continuity of follow-up. This includes the community midwives, health visitor, antenatal class coordinator, and general practitioner. Other existing carers such as psychiatrists, secondary care specialists, and drug workers should also be contacted. It should also include voluntary groups who distribute free items to new mothers, but specific details should not be released to maintain confidentiality. Appointments for antenatal clinics, hospital and community, ultrasound scans, and preoperative assessment should be canceled. Psychological and social aspects of care. What psychological problems can follow late intrauterine fetal death? Carers must be alert to the fact that mothers, partners, and children are all at risk of prolonged severe psychological reactions, including post-traumatic stress disorder, but that their reactions might be very different. Perinatal death is associated with increased rates of admission owing to postnatal depression. Unresolved normal grief responses can evolve into post-traumatic stress disorder. Women with poor social support are particularly vulnerable. Partners of women with an IUFT can also suffer from severe grief responses, but the prevalence of such psychological disorders in partners is not precisely known. Men demonstrate less guilt, anxiety, and depression than women themselves, but they can also develop post-traumatic stress disorder. Discordant grief reactions between partners are more common after IUFT than after neonatal death, and this is a risk factor for prolonged and abnormal grief reactions. Parental relationships have a 40% higher risk of dissolving after stillbirth compared with live birth. What is best practice for use of interventions that might aid psychological recovery? Carers should be aware of and responsive to possible variations in individual and cultural approaches to death. Counseling should be offered to all women and their partners. Other family members, especially existing children and grandparents, should also be considered for counseling. Debriefing services must not care for women with symptoms of psychiatric disease in isolation. Parents should be advised about support groups. Bereavement officers should also be appointed to coordinate services. Some parents develop prolonged psychological problems after stillbirth. This appears to be much more likely if professional support is not given. Guilt is a common emotion but is not necessarily voiced. Carers should carefully seek to identify false assumptions made by parents and communicate this to counselors. Other members of the family can also be severely affected by bereavement. The most common response of grandparents was a profound need to protect their own child. The study found that grandparents need information on how they can help the children recover from their loss, how long grief lasts, and the differences between men's and women's grief responses. Child-parent relationships can be adversely affected if the parents have great difficulty coping with their loss. Some parents wish to have guidance on how to explain the death to siblings and how to help them mourn. Support groups such as SANS or Stillbirth and Neonatal Death Society have been developed to offer help to both partners. The introduction of bereavement support officers has been shown to improve the management of perinatal loss. What is the evidence for seeing, holding, naming, and mementos? Carers should avoid persuading parents to have contact with their stillborn baby, but should strongly support such desires when expressed. Parents who are considering naming their baby should be advised that after registration, a name cannot be entered at a later date, nor can it be changed. If parents do decide to name their baby, carers should use the name, including at follow-up meetings. Parents should be offered, but not persuaded, to retain artifacts of remembrance. Maternity units should have the facilities for producing photographs, palm and footprints, and locks of hair with presentation frames. Verbal consent should be sought from the parents, and information governance regulations should be complied with for clinical photography. If the parents do not wish to have mementos, staff should offer to store them securely in the maternal case record for future access. It should be explained that clots on a macerated baby might become stain. Some parents may wish to name their baby, but others decide not to do so. Either option is allowable in law, but once a stillbirth has been registered, names cannot be added or changed. According to Births and Deaths Registration Act of 1953, amended by the Stillbirth Definition Act of 1992. Keeping mementos has not been associated with adverse outcomes, and qualitative studies have shown that many parents value them highly. What are the legal requirements for medical certification of stillbirth? Obstetricians and midwives should be aware of the law related to stillbirth. The following practice guidance is derived from statute and code of practice. Stillbirth must be medically certified by a fully registered doctor or midwife. The doctor or midwife must have been present at the birth or examined the baby after birth. HM coroner must be contacted if there is doubt about the status of a birth. Police should be contacted if there is suspicion of deliberate action to cause stillbirth. The parents are responsible in law for registering the birth, but can delegate the task to a healthcare professional. Fetal deaths delivered later than 24 weeks that had clearly occurred before the end of the 24th week do not have to be certified or registered. The baby can be registered as indeterminate sex, awaiting further tests. The current law on stillbirth registration is set out in the Births and Deaths Registration Act of 1953, amended by the Stillbirth Definition Act of 1992. The legal definition of stillbirth is any child expelled or issued forth from its mother after the 24th week of pregnancy that did not breathe or show any signs of life. Legal advisors for the Department of Health and the Office for National Statistics have agreed that a fetus that is expelled after 24 weeks of pregnancy, provided it was no longer alive at the 24th week of pregnancy, this fact being either known or provable from the stage of development reached by the dead fetus, does not fall within the category of birth to be registered as a stillbirth under the above acts. When the gestational age is not known before the birth, with unbooked pregnancies, for example, the decision about the status of the birth should be made on the basis of the stage of development of the baby on examination. The doctor or midwife attending the stillbirth is required to issue a medical certificate of stillbirth that enables the birth to be registered. The cause and sequence of medical events leading to the IUFD should be given in as much detail as possible. Non-specific terms such as anoxia, prematurity, and so on should be avoided. Certification should not be delayed for the results of the postmortem. The mother or father, if the couple were married at the time of birth, is responsible for registering the stillbirth, normally within 42 days, 21 days in Scotland, but with a final limit of 3 months for exceptional circumstances. This responsibility can be delegated to health professionals, including a midwife or doctor present at the birth, or a bereavement support officer. The person registering the birth has to be able to provide the following: the place and date of birth of the baby. If the parents wish to name the baby, the name and surname. the sex of the baby, but can be registered as indeterminate and later changed if tests show a clear result, the names, surnames, places of birth, and occupations of the parents, the mother's maiden name if applicable. In Scotland, the marriage certificate of the parents is required. The Registrar of Births will meet the parents in private. The birth is entered onto Stillbirth Register, which is separate from the Standard Register of Births. The parents are then issued with a certificate of stillbirth and the documentation for burial or cremation. A certificate for cremation cannot be issued before the registration. If information about the father is not recorded initially, it is possible for the birth to be re-registered to include his details later. HM coroner does not normally have jurisdiction over stillbirth, even if the cause of death is not known, but contact should be made for an apparently fresh stillbirth not attended by a healthcare professional. HM coroner also has discretion to be involved if the death followed a criminal act such as common assault and can then request for any postmortem to be expedited. If there is suspicion of actions taken deliberately to cause stillbirth, the police service should be contacted. What are the recommendations for spiritual guidance, burial, cremation, and remembrance? Maternity units should have arrangements with elders of all common faiths and non-religious spiritual organizations as a source of guidance and support for parents. The legal responsibility for the child's body rests with the parents but can be delegated to hospital services. Parents should be allowed to choose freely about attendance at a funeral service. A leaflet about the options should be available. Maternity units should provide a book of remembrance for parents, relatives, and friends. Carers should offer parents the option of leaving toys, pictures, and messages in the coffin. What advice should be given about fertility? Information about fertility and contraception should be offered to mothers before returning home. Mothers are vulnerable to psychological disorders when conception occurs soon after the loss. With suppression of lactation, ovulation returns more quickly. This can be as early as day 18. Some women may not be aware that they might conceive before their first menstrual period. Follow-up. What are the options for follow-up meetings? The wishes of the woman and her partner should be considered when arranging follow-up. Before the visit, it is essential to ensure that all available results are readily to hand. Some parents find it very distressing to return to the unit where their baby was stillborn. If practicable, the option of home visits should be offered to parents. Office consultation has the potential advantages over clinic follow-up of preventing waits and allowing flexible duration. Six to 8 weeks is common practice for the timing of the appointment, When the placental and the postmortem histology results usually become available, but a flexible approach is appropriate according to the needs of the parents and the range of tests performed. What are the recommendations for the content of the follow-up appointment? Parents should be advised about the cause of late intrauterine fetal death, chance of recurrence, and any specific means of preventing further loss. Women should be offered general pre-pregnancy advice, including support for smoking cessation. Women should be advised to avoid weight gain if they are already overweight or a body mass index over 25 and to consider weight loss. An offer should be made to discuss the potential benefit of delaying conception until severe psychological issues have been resolved. Carers should be aware that while mothers tend to experience greater anxiety when conception occurs soon after a fetal loss, partners are more likely to suffer anxiety if conception is delayed. Parents can be advised that the absolute chance of adverse events with a pregnancy interval less than 6 months remains low and is unlikely to be significantly increased compared with conceiving later. The meeting should be documented for the parents in a letter that includes an agreed outline plan for future pregnancy. The meeting can also focus on the prognosis and options for future pregnancies. The discussion should cover general preparation for pregnancy, lifestyle, folic acid supplementation, and rubella vaccination. Parents often desire an open, honest discussion with an opportunity to make comments and a chance to raise any concerns they might have. If care has been suboptimal, parents might want this to be acknowledged, lessons to be learned, and care in the future to be improved. Vulnerability to depression and anxiety in the next pregnancy is related to time since stillbirth, with more recently bereaved women at significantly greater risk than controls. In contrast to mothers' vulnerability to psychological disorder when conception occurs soon after the loss, fathers tend to experience greater problems when pregnancy is delayed. Interpregnancy intervals shorter than 6 months were associated with increased risk of preterm birth, low birth weight, and small for gestational age babies. The odds ratio for stillbirth for women who smoke is 1.6. Women who stop smoking have equivalent stillbirth rates to women who have never smoked. Pregnancy following unexplained stillbirth. What recommendations should be made for pregnancy following unexplained late intrauterine fetal death? The history of stillbirth should be clearly marked in the case record, and carers should ensure they read all the notes thoroughly before seeing the woman. Women with a previous unexplained IUFT should be recommended to have obstetric antenatal care. Women with previous unexplained IUFT should be recommended to have screening for gestational diabetes. For women in whom a normally formed stillborn baby had shown evidence of being small for gestational age, serial assessment of growth by ultrasound biometry should be recommended in subsequent pregnancies. Women with a history of stillbirth but otherwise low risk had a 12-fold increased risk of intrapartum stillbirth, an increased risk of preeclampsia, and placental abruption. The increased risk was independent of recurrent maternal conditions and fetal congenital anomalies. A significant proportion of unexplained IUFDs are reclassified as fetal growth restriction when customized charts and different classification systems are used. What recommendations should be made for the management of future delivery after unexplained stillbirth? Previous unexplained intrauterine fetal death is an indication to recommend birth at a specialist maternity unit. Previous IUFT related to a known non-recurrent cause merits individual assessment for place of birth. Maternal requests for scheduled birth should take into account the gestational age of the previous IUFT, previous intrapartum history, and the safety of induction of labor. What recommendations should be made for maternal care after the next birth? Carers should be vigilant for postpartum depression in women with a previous intrauterine fetal death. Carers should be aware that maternal bonding can be adversely affected. The birth of a healthy baby does not compensate for a previous loss and can trigger a resurgence of grief. Women might feel happy one moment and sad the next. Depression in the third trimester is highly predictive of depression 1 year after subsequent birth, particularly for women who conceive within less than 12 months from an IUFT. Unresolved maternal grief may result in disorganization of attachment with future babies. Clinical governance. Are there any risk management standards for intrauterine fetal death? Maternity units should be aware of specific standards for IUFT and stillbirth. What are the standards for documentation? Standardized checklists can be used to ensure that all appropriate care options are offered and that the response to each is recorded. Consent for perinatal post-mortem examination should be documented using the nationally recommended form. All stillbirths should be reviewed in a multi-professional meeting using a standardized approach to analysis for substandard care and means of future prevention. Results of the discussion should be recorded in the mother's case record and discussed with the parents. All stillbirths should be reported to the Center for Maternal and Child Inquiries, or CMA-CE. Information leaflets. All women and partners should be offered leaflets that provide information on the following issues: name carers, local contact points, postmortem, nature, benefits and choice, expectations for physical recovery, lactation suppression, registering the birth including web addresses of local authority site, details of national and local parent support groups such as SANDS, guidance on fertility and contraception, and plan for follow-up. What is best practice for care of staff? A system should be in place to give clinical and psychological support for staff involved with an intrauterine fetal death. Occupational health should be contacted for advice if there are particular concerns about fitness to work. Improved bereavement training can help staff care for grieving families, but can also help staff cope with their own emotions.